Good evening, delegates. Let me welcome you all at the ninth out of its CV Journal Club meeting, the journey which we have started exactly a year back. And it's a ninth in a row session to talk about the latest update from the various interventional cardiology journal. And it's our immense pleasure to conduct these programs with the entire eminent panel. And this time we are discussing three topics which are relevant to the interventional cardiologist's day-to-day practice, and of course something newness to the discussion. And the entire faculty panel is available with us to discuss the relevance to the day-to-day practice. So without wasting much time, once again, it's my honor to welcome our esteemed moderator, Dr. Anil Dhal from Delhi. Also, along with us, the faculty, Dr. Dilip Kumar sir, Sarita Rao madam from the Indore, Dr. Pranit Polamuri, and we also have Dr. Prashant Gautam from SGBJ Lucknow presenting those studies to all of us. So that's it, sir. I think we can go dive into the scientific twist. So let me hand over to Dr. Prashant Gautam. Doctor, please, over to you.
Thank you so much. Good evening and warm welcome to our esteemed panelists and to everyone who have joined in. Today we have gathered to discuss three important and long debatable topics in cardiology, in which we all have doubts and we want clarity regarding the better patient care. So I will just first summarize these topics and then invite our panelists for the panel discussion. Okay. I will share my screen. So the first article for discussion is the transcarotid versus the surgical aortic valve replacement for the treatment of severe aortic stenosis. It was published in Circulation, and the main topic of discussion that according to the guidelines which recommend that the surgical aortic valve replacement for severe aortic stenosis is recommended in patient with unfavorable iliofemoral access. So transcarotid transcatheter aortic valve replacement is an alternative for patients who have unsuitable transfemoral access, and there is no prior data which directly compare transcarotid tower versus SAVR, and making this a study novel. So this study first provides the comparison between the transcarotid versus the transcatheter aortic valve replacement and surgical aortic valve replacement. It is a study which shows an alternative to non-transfemoral transcatheter aortic valve replacement. The patients who have unfavorable anatomy for transfemoral access for TAVR, which can go for SAVR as well, but the advantage of transcarotid TAVR, which this study enumerates. So the clinical challenges encountered are the patient with severe aortic stenosis, patient having the access limitation, and the knowledge gap is there that there's no direct evidence between transcarotid TAVR versus the SAVR. So this study was designed, and the study is a single-centered study. Patient selection were the patient with severe AS with unsuitable iliofemoral access, and the 180 patients were taken in both the groups, and the primary outcomes were the composite of death in stroke, TIA, and the valve-related hospitalization, and it is measured at around 30 days and 1 year. So the 30-day outcomes were the primary composite outcome of death, stroke, or rehospitalization at 30 days and 1 year. So the advantage with the transcarotid TAVR were that there were shorter stay, less bleeding, fewer arrhythmias, and less kidney injury. And the challenges encountered with transcarotid TAVR were the vascular complications, pacemaker implantation, and it needs specialized training. So to summarize, this study compares the transcarotid TAVR versus the SAVR, and it has the benefits of transcarotid SAVR, like there is the less bleeding, and the comparable outcome as compared to SAVR. So now I will invite the speakers to have a discussion on this topic.
Do we have Dr. Dhal sir is there? Otherwise, we can kick off the discussion. I
So
think.
we have Dr. Dal. I think sir is seeing a
Yeah,
patient
sir.
at the moment, I guess.
Yeah, I think you all can just carry on just to have a starting point as to understand. We all know the challenges with transcarotid delivery. Now, and we all understand that if we do not have a transfemoral delivery, which is easy, we might have to switch to a transcatheter delivery. Now, we want to know whether this should be standard of care practice. So let's have a discussion on how many people actually feel that they would like a transcarotid to be a bailout procedure, or whether they think it can actually be considered to be a standard of care practice.
So, sir, I think this is the first study which has been done in a randomized fashion, the transcarotid versus surgical aortic valve, arm. And at this moment, none of the guidelines they have got endorsement for a non-femoral tower. So, transfemoral tower is the one recommended therapy in low risk, intermediate, high risk patients. And if we don't have any access transfemoral which is feasible, and patient is very high risk for surgery, only then we can think of alternative access. And amongst these alternative access, subclavian, carotid, and transcaval, the transcarotid is more appealing because this course is very straighter. The surgeons do the job of giving you the cut down the carotid part, and you have to just take the catheter down, which is very straight. And doing transcarotid tower is a easy job than transfemoral even. Uh, the only thing which is there with transcarotid is you have to have a surgeon involvement. But subclavian we can do, transaxillary we can do with percutaneous method. And but the superiority or this kind of study where transaxillary access tower is being compared with SAVR is not done, and they have got their own limitations. So I think it's a very uh, good study which has shown superiority of transcarotid tower on surgical aortic valve replacement. So we may have a recommendation in future if such studies of larger population come in, where it shows safer as well as a good option, where less bleeding, less of mortality at 30 days, less of atrial fibrillation, then with transfemoral transcarotid can be added on.
I think this study actually opened up new vistas of care, especially many a times we have a patient who's not fit for surgery and at the same time doesn't have a good iliofemoral access. And then we are stuck at that time as to what to do. And the very fact that they have shown in this fashion the results of a transcarotid access with good results is it opens us options for us. And very rightly said that, if we are going transcarotid, we need specialization and we need training in that because all cardiac interventionists are very well trained in going the transfemoral way. But in carotid, we are not. So we would need to get more training in that, involve more people in going transcarotid, and our results would depend on that. But very interestingly, in this study also, then they saw that the SAVR arm versus the transcarotid arm, the transcarotid arm had a very higher incidence of pacemakers. It was 4.4 versus a 15.9% incidence of requiring pacemaker implantations. And the vascular complications are also more. So they had 0% versus 4.9. So transcarotid, I think, will need more expertise, more training in that. But the very fact that it can be done safely for patients who can't really go in for a SAVR or who have a poor iliofemoral access opens up more vistas of care for us. Interestingly, when you go transcarotid, the incidence of stroke is almost similar. It was 3.8 versus 2.7. So going transcarotid, the incidence of stroke rates were almost similar in both the arms, the SAVR versus the transcarotid. So that's an interesting point because when you're going from up, that difference happens then.
So I have a different take on this topic. I will kind of differ with the study findings, particularly in terms of the Indian context. When we are talking about transcarotid TAVR, the two things I would look into is about the stroke risk, because we are manipulating carotid artery, and I would be worried about the experience of the surgeon doing carotid access and giving it to me to perform the TAVI. So the expertise, as ma'am was mentioning, in terms of giving a proper vascular access, manipulating the carotid artery. So the risk of stroke increased with the manipulation of the carotid artery. Also, the advantage of anesthesia, which we avoid by doing transfemoral TAVI compared to a transcatheter TAVI, where we are putting the patient again under general anesthesia. So if I have to take it, I would be more willing to give my case to a surgeon who is more comfortable or who has a better experience in doing a surgical aortic valve replacement. Also understanding that the expertise of surgeons are currently is increasing in doing minimally invasive surgical valve replacement. So if I'm not very confident about the vascular surgeon in terms of how many interventions or surgeries that he performs on carotids, because these days we are also doing TAVI in centers where there is no surgeon available. Forget about a vascular surgeon available. So, looking into that aspect, I would be happy to give my case to a surgeon whose outcomes, in my opinion, will be better in comparison to a vascular surgeon for whom I'm doubtful that he would be reducing the stroke risk. So, if these findings I would take with a pinch of salt, and I would be cautious in sending these patients. So, I would not do a transcable unless I don't have any other option.
Yeah, but let's just examine one point. Why was the pacemaker implantation rate high? Is this a beta error? Is this because of the cohort size, or is it because of some issues in patient selection? Was it related to pre-existing conduction blocks, or was that adequately randomized? Is something which we need to figure out. As far as getting carotid access is concerned, I mean, you probably all know that even for carotid interventions, there is a rise in the utilization of the Silk Road technology, which by and large avoids even femoral access and does direct carotid access. So and also in terms of the performance of the procedure, since we avoid the aortic arch or crossing, a calcific aortic arch, it is easier, if you were to say mechanically, it were to be considered deemed easier, although we would all like to have those Superman type of transcable access, or maybe we would like to do a CT beforehand and get a subclavian or axillary access, or the braver amongst us may even do a direct LV puncture. But really, carotid is not such a difficult access. I'm a little surprised at the pacemaker rate. I'm also a little surprised at the delayed complications not being increased, and also that the stroke rates were similar. So I think the cohort size has something to do with it. And in our limited judgment, I would suggest that this should still be kept as something, a center which has high volume work, which might deal with adverse femoral access, can deal with, but not become a standard routine, standard of care procedure.
Yeah, sir. And coming to the point, why pacemaker rate was higher? Because after all, it was TAVR versus SAVR. So it will reflect in the same manner. So transcatheter valve will be giving more pacemakers than a surgical when you are implanting a valve surgically. And that is what is being reflected here. And I totally agree with Anil sir that exposing the carotid is not a very complicated surgery. And it's a kind of easy procedure for most of the surgeons, cardiac surgeons, and it's feasible. The only thing is technically, if the exposure is good, doing a transcarotid TAVR is not difficult. Unlike in subclavian axillary, there are tortuosities. Here you get a straighter course. Your orientation has to be a little bit, changing here. But it is a good option when we talk in, in forums like Dr. Ramesh Dagubati is a very strong proponent for transcarotid, and he says if we don't get any iliofemoral access, if surgeons are not willing to go for surgical aortic valve because of severe COPD and all, so we go for a transcarotid we prefer this route more than transcaval or transaxillary.
But there's a
Say
question on the
that,
group
that
that if there is
because
associated disease, then you avoid that site.
so I was just on that point which Dr. Dilip said and Dr. Dal also said that actually when you go transcarotid, you're supposed to have less pacemakers because it's a direct route and it's a short access length. So basically, you're supposed to cause less trauma to the conduction system. So it was noted that there should have been fewer cases requiring a pacemaker. So what Dr. Dhal said that it was probably the problem in the cohort which they used. So probably those people probably had pre-existing conduction system abnormalities, and probably that is why this came in. Because otherwise, when you go transcarotid, the incidence of requiring pacemaker should have been less because of the direct route, which reduces the amount of pressure and force exerted on the surrounding tissues, including the conduction system.
Great. So any other questions from our participants? I mean, because obviously the truth is that we can't really think of transcarotid as a standard of care option. However, as a fallback option, it avoids the arch. It avoids doing complex aortoiliac manipulation and procedures, and sometimes treating the calcium in the aortoiliac region. And it is easier for the interventionist, places a little bit of vascular control issues for the surgeon. Shall we move on to the next case? Next paper.
Dr. Prashant?
Prashant, anything? No.
I think Dr. Prashad, you are on mute.
The second topic for discussion today is the article published in Urointervention. The topic is the final kissing balloon dilatation in patient with coronary bifurcation lesion treated with an upfront provisional stenting strategy. We all know that the provisional stenting strategy is was the major strategy for treatment of the bifurcation lesion, and the stenting the main vessel with optimal side branch intervention remains a query in all of us. So the final kissing balloon technique, that is the simultaneous balloon inflation in both the vessel, is the technique. There is uncertain benefit of FKBI in provisional stenting. So in this study, they have that is the bifurcate study. They have retrospectively analyzed the two registries, that is the bifurcate and the ultra registry, and they have combined the data, and they have deduced the outcomes in terms of MACE and also the lesion-oriented outcomes. In this study, they have found that the FKBI was associated with a lower rate of lesion-oriented composite outcome, that is the target vessel MI and the target vessel revascularization. But there was no significant difference in the MACE. So it is a bad. So over to you, sir, for discussion.
Yeah, I mean, so firstly, we have to understand one small thing about this study. This is not an original study designed, a prospective randomized control trial, which we all understand would be required to sort a very, very important day-to-day clinical issue. Whether we do side pod side, or we do just individual without a pod, and whether we do a final casing. Now, this is propensity matched analysis, and I think that as we have advanced in medical statistics, and a lot of modern publications are going to be propensity matched analysis, which means that they will take these from the existing study. And here we have the COBIS registry, we have the RAIN, and we have one more registry, which they have taken the data from there. We have tried to see which are the ones which are true bifurcations, larger side branch, smaller side branch, and seen how this progresses. So I am not, being a purist at heart, I would always be a little suspicious about when we use propensity matched analysis. I also know that in modern day pharmacotherapeutics, this has become almost standard of care. Many of the SGLT2 trials, many of the other trials are all using propensity matched analysis. But in an interventional arm, especially when the cohort size could be reasonable with the kind of cases that we do, and we can then phenotype them separately, prospectively. I think the relevance of this data is not as much as if a prospective study were to be planned.
Yeah, so I think this also explains our practice. Like we Indian operators, we don't do a final kissing until and unless we see there is a severe pinching or a slow flow or something. We have created some dissection where the side branch is compromised, as compared to European colleagues and maybe Chinese colleagues as well, where they do routine kind of final kissing balloon. Even if there is a 80%, some 70-80%, but still TIMI3 flow is there in side branch, they go for a routine final kissing balloon. So these studies like COBIS 1 initially showed results otherwise, saying, giving the information that routine strategy could be leading to higher TLRs. But COBIS 2 again showed us that no routine, more than 2.5 vessel, a routine final kissing balloon can be giving us more larger area and lesser TLRs. And this, this is registry data which is being studied, 2-3 registry data which has been analyzed. And again, they have shown that this COBIS 2 finding is again validated. More than 2.5 vessel, the odds of having a better outcome with lesser TLR is high. But I strongly agree with sir that these are propensity match registry data. We don't have an RCTs on that. So I would still be choosy in my practice. It will not be any different with these studies coming in. Changing my practice that we'll be going after every bifurcation more than 2.5 as a fighting kissing balloon. I will be choosing only.
I think when we talk about, this study, so initially why they wanted to, see about filing kissing was that they wanted to see that, if you do a final kissing, it will restore the, distortion because of the initial ballooning. The distortion of the stent symmetry will come back. Okay. But then the other group thought that, when you do a final kissing, you actually end up damaging the polymer. And when you damage the polymer, you also end up reducing the drug delivery. And then when you do that final kissing, depending on how you've placed your kissing balloons, there will also be a proximal segment elliptical deformation. So there's a residual stent deformation by the final kissing also. So these were the two schools of thought. Now the problem is because it's a registry and they've looked at many data, we don't really have any idea about how exactly the kissing was done in all of these portions. Was it the same technique which was used? Did they do pot in all of these patients subsequently? What was the amount of overlap of the balloons? Did they use imaging or did they not use imaging in these cases? So a lot of questions come up. So final kissing balloon, again, in my practice depends on case to case. It's not mandatory after every provisional. It would depend on what was your result at that time. So they didn't really find any benefit in doing final kissing. But if you looked at the loco, they actually had a benefit in the loco with that.
Yeah, I think perfection is the enemy of good. So sometimes we kind of get carried away that we have to follow the textbook and you have to go through all these steps, and it is mandatory that you have to do final kissing balloon inflation, and you'll be penalized if you haven't done final kissing balloon. That was the earlier thought process, but I think it is more practical at this point of time to consider the overall result. The more manipulation that we are doing, as ma'am was saying, we will be damaging the polymer. We shouldn't be expanding stents or repeated balloon dilatations, high pressures particularly. damaging the polymer, and again distortions, guide sucking in, longitudinal deformities, and equally increasing the maze events by staying in the coronary and irritating that coronary for longer period of time. And I think the bottom line of making a decision case to case, and if you think that adequate lesion preparation, proper or liberal use of imaging, and if angiographically and imaging wise, if you can achieve a proper surface area, I believe few of these steps can be avoided, and we can still get away a proper long-term result.
Well,
So I
one of
always feel that, making a bifurcation as simple as possible
them.
is the best way to go. An acceptable result is good. And when you're doing a bifurcation, you also always have to worry about, the fluoroscopy time, the contrast usage, the radiation that you're getting. So for me, I like to make bifurcations as simple as possible. I get an acceptable result. I don't chase after that final kissing when we're going provisional.
But one thing is very clear, Praneeth and Dr. Sarita and Sir, that less than 2.5 vessel, but all factors which we just discussed, deformation of stents and polymers and all, they become the dominant factor. So whenever, even if we are choosing for final casing balloon in provisional stenting, this is a provisional stenting. It's not the two-stent strategy. Provisional stenting, when we have gone a crossover stent from main vessel to not in the side branch, and then we are doing a final casing, the side branch should be at least more than 2.5. Then the kind of anatomy we are creating, which this is becoming a dominant factor, and not the stent deformity and the other factors, which plays a major role when the vessel size is lesser.
So even
Yeah.
that, having said that, even before when they tried to see the same thing with the Excel trial. Even in that, they found that the final kissing balloon did not show any benefit.
Yeah, but it's so strange that after so many years and decades of doing bifurcation PCI, the practice remains so geographical. I do not know whether this is egos or politics or what it is. I mean, the our Eastern colleagues, whether it is, I'm not saying east of India, but if you look at the Chinese, the Korean, and even the Japanese, they believe in different techniques like the gel balloon technique. They would try to use more dedicated two-stent strategies, whereas Europe has insisted upon, by and large, sticking to at outset provisional approach. And it's only with great reticence they have allowed some two-stent strategies to come in. So if you look at the major data of provisional, it would still be largely coming from European cohorts, but some of this which they have seen are non-European trials. So therefore it leads me to really be a little suspicious about this data.
So I think now, with the advent of DCBs, bifurcation is going to become a lot more simpler.
Next topic is DCP and bifurcation.
So very clearly, I completely concur. I mean, as Sarita said, I was going to use exactly the same words. Keep it as simple, but not simpler. It should be as simple as possible to have a good result. The challenge in our thought process is going to be, because we are sometimes not just happy to leave something, we should also not regret having left it later. Because some of these things come back and haunt you at a later date. So therefore, even acute results are not always representative of what you would like to do in real life practice, because you can get an angiographic, very pretty acute result. But when you come back and look at the same thing, you are actually banging your own forehead and thinking, why did I not do this? But you're all very right. With the use of drug-coated balloons, we probably would treat the side branch with more drug-coated balloons as time goes on.
Yes, and I think the use of more and more imaging, more and more physiology helps us to really decide about the side branch.
So, Praneeth, any comments?
I think we have one question. I think we should answer that. What are the clinical indications or angiographic features that should guide the decision to perform final kissing balloon dilatation after provisional stenting in bifurcation lesions?
So that is the debate, Praneeth, we are having.
There's a
So
chat question, I think.
yeah, so if there is a slow flow, if there is a severe pinching, if there are, and there is not a TIMI3 flow, you have to go for a kissing, and if it is not restored, you have to go for a bailout stenting of the side branch. So suppose we are getting a kind of a distortion and then the side branch which looks like more than 70%. So we can go with imaging, we can look at the MLA, we can go for FFR. If we see the FFR is positive, then we can definitely think of going for a kissing balloon. Otherwise, we can leave it like that. This is our practice, I think, and this is also being kind of reaffirmed and re-endorsed with all these findings which are coming up.
See, the
Agree.
only problem whenever we go for a final kissing balloon dilatation and provisional stenting is that many a times you need to convert then into a two-stent technique.
Yeah.
So that is the only thing that you have to be prepared with. So if you see that you are having a significant amount of flow reduction, there's a significant pinch, and then you're going to go in and do a final kissing, you know that you also have to be prepared in the event that you have a dissection that you will convert into a two-stent strategy.
Yeah, I think this is a common vexing problem day to day, and everybody is given the outlines as to how they would practice it. I think we'll need more data before we can actually say that, and I don't think there will ever be data where we can say yes to a final kissing and all, or ever say no to a final kissing and all. I think it will all have to be individually the discretion of the operator in a given case is going to be important.
I agree.
So I think we'll move on to the
Next case, next paper.
next. Yeah, we all say case, right?
Yeah, they're so used to that.
I made that mistake a little while earlier.
Yeah, I know.
Sir, the third topic is also related to the bifurcation lesions. As ma'am said that the DCBs are an attractive alternative to the stenting the side branch. So the topic is the trial is the spacious trial. It is sirolimus coated versus the paclitaxel coated balloons for the bifurcation coronary lesion in the side branch. The aim of this study was to investigate the sirolimus coated balloon versus the paclitaxel coated balloon in left main coronary bifurcations. It is a prospective non-inferiority multicentral trial, and it incorporated 230 patients, and they were randomized in 1:1 ratio for sirolimus versus paclitaxel coated balloon in the side branch. And the primary endpoint was the diameter stenosis in the side branch at 9 months and 1 year.
Your slides are not moving. Your slides are not moving.
Yes, sir. Yes. And the patients were angiographically and clinically followed up for the 9 months and 1 year. And the primary endpoint were the diameter stenosis in the side branch at the 9 months. In this study, they found that the sirolimus containing DCBs are non-inferior options to the paclitaxel containing DCBs. Over to you for discussions.
So I think this is again, and which were the because I didn't get the chance to review the paper. So which were the balloons used in which are the paclitaxel coated and which were the sirolimus coated balloons used? Was it mentioned?
I think this is a pool data where like it was not a particular fixed sirolimus. It was comparison of the different types of paclitaxel versus sirolimus. And for me, it was an equalizer. So we had a transform one trial which had showed that paclitaxel eluting coated balloons are giving larger MLA, and that is and than the sirolimus coated balloons. And this study has shown sirolimus coated balloon has less binary restenosis. So it reestablishes the fact that both the balloons are kind of giving us equal result as of now. At 1 year, there is no mortality difference, and we are going to get even long-term results. And both looks promising, and we can't be giving one as an edge over other, which is being also shown in this study. Clinical endpoints were similar.
So they haven't mentioned actually which balloon, but they did write that this was a balloon which was approved in China, and that this paclitaxel coated balloon had not been tested against other balloons till then, but it was officially approved for use in China, is what they said. Now, this study typically has a very it was non-inferiority, and it was a short follow-up. So they only did a 1-year follow-up, 9 months to 1 year follow-up. Again, they also included only lower risk patients. So the high risk patients were excluded from this study. And again, they looked at patients, many a times they were not able to remove the oculostenotic reflex for the ischemia. And also imaging was absent in this study. And while it is similar, but what was interesting was that the binary restenosis rates were actually lower in the sirolimus group versus the paclitaxel. It was 4.4 versus 12.8. That is very interesting because the late lumen loss and the net luminal gain at 1 year was the same, but the binary restenosis was lower in sirolimus, which is interesting.
So it's one versus one. Pradith and Anil sir's opinion on which.
Yeah, because you must understand, whenever we are analyzing drug-coated balloons, it is not only the drug which matters, even the excipients matter, because we don't have perfect means of determining drug delivery to the vessel wall. Just an application differs with different excipients which are used. The different, whether we're using urea, whether you are using nanoparticles, whatever we are using, it also makes a difference as to how that is being done. Thirdly, the techniques have to be completely standard, because what happens when you are not using standard techniques, I do not know if you are getting adequate drug delivery. And for that matter, sometimes even plain balloons don't give such bad results. So really, this is a field where, and Sarita very rightly pointed out, getting a binary restenosis which is better in sirolimus than in paclitaxel would lead to a lot of question marks in my mind, because paclitaxel has certain inherent advantages by virtue of the fact that it is easier to transport a balloon paclitaxel on it to the coronary, and much easier to deliver the paclitaxel to the coronary than with sirolimus. However, this cohort is too small. I think 230 patients is a rather cohort for us to draw very, very viable conclusions. And also because this is geographically limited, so we are not very confident of the product, which is the Chinese FDA has approved it, but we do not know, like I said, the individual drug-coated balloons do have differences in their mechanism and the amount of drug which is delivered. So maybe if we were to make it agnostic and just make it of the excipients and just make it about the molecule, then we probably need to enlarge the cohort to draw viable conclusions.
Very rightly said. Because in this, like you were talking about the excipients, and they used magnesium stearate and butylated hydroxytoluene as excipients, and that typically carries a very high drug concentration. So we don't know if that would change, would the results also change. But another interesting thing which came in that was in the use of coronary bifurcation lesions, using a DCB in the side branch actually was not associated with any increase in procedural complications. So the other side part, the implication was that it's a good option for our bifurcation lesions.
You've already made that point, and we all accepted that it is a good option. However, we must be careful in interpreting such data.
But in fact, in 2024, sir, there have been 5 meta-analyses have been published for each category: acute myocardial infarction, native large vessels, and bifurcation. And they all have shown that with drug-coated balloons, the end results are not significantly better, but it is better. This is, and there is no flags, red flags there. There was a lesser kind of ISRs and lesser TLRs were there. And all the data is moving towards DCBR. And that is where Dr. Colombo has got the conviction also. We all have seen in India Live what a difficult case in a large vessel. There was a dissected and he left with a drug-coated balloon. So all meta-analysis, I was just reviewing those meta-analysis today, and none of the meta-analysis they have shown that DES is better than DCB. All have shown DCB, the trends is in favor of DCB, although not very significant. Clinical endpoints are more or less similar. So
typically, unless you have a dissection which is more than C, you
C.
walk away with the DCB. And unless you have a residual stenosis of greater than 30%, you can walk away with the DCB.
Yeah, because DCB is likely to do some medial remodeling, and therefore there lies an inherent advantage. Actually, more the dissection, the more possibly the DCP will act, and therefore the other question which has been doing the rounds is that should imaging be mandatory whenever we're using DCB, and not that every imaging can actually provide us insight into every micro dissection.
So I don't think it has to be mandatory, because the type of dissection can many a times be also seen angiographically. And Dr. James Eccleshall, who's doing the largest de novo study on these paclitaxel coating balloons, he swears by it that he typically does most of his work angiography guided, not imaging guided.
In Simon Eccleshall's lab, 95% of cases, 90% to 95% of PCI are done with DCB.
Yeah, he does most of his work with DCB, and he does a lot of work on de novo lesions. So basically, I think
doesn't matter if it is vein graft, if it is a primary, it doesn't matter if it is a calcific lesion, a CTO, he will end up with a DCB.
And actually, the results that he has are amazing, and it's an eye opener for us, because if you look at it, we never thought of doing a CTO earlier with a DCB, but today we do. It's actually a very safe subset to do a CTO with a DCB. And because when you take a check shoot a year later, the vessel is remodeled, and there's a late lumen enlargement also. So it's an expanding indication of DCBs that we are looking at more and more. And typically, we are unlearning the traditional way that we used to work with DES. When we were sure that we're going to put in a stent over there, we used to typically go high pressure, create all kinds of dissections, because we knew we were going to seal it with the stent. But when you're going with the DCB, you go simpler and you go less higher pressure, and you gradually up titrate your balloon size. You use a cutting to create the controlled dissections that you would want the drug to deliver through. It always helps, coming back to the original question, always helps to have imaging in the lab. But not having imaging doesn't mean that we can't do DCB. You can still do it beautifully.
I think it all looks good and fancy, but the practical aspect is the one which is challenging, and that is where is the question which has been brought up in chat, that there is a cost difference in India for two DCPs, and will it impact the use of DCP with this? Because most of the patients, they have approval for only stent. Unfortunately, even for insurance and for most of the government schemes, DCBs are not approved. Stents are approved. And second, if we are using a DCB, and if in case we have a flow limiting dissection post a DCB, what if then? Then we have to again forced to put in a stent, and who would take the additional cost of the stent that we have used? And the challenges with using DCB is the same thing, that about the dissection, flow limiting dissection, and convincing them about the so-called procedure. I believe even the awareness of DCB among public is still limited. When we talk about DCB, it looks something which is fancy. So getting their confidence in doing a DCB is equally challenging. I would like to take thoughts about this entity.
Yeah.
So this is very interesting because, you know, first of all, upfront explaining to patient about the DCB is important. And secondly is that what we've learned is that once I've prepared the vessel for a DCB, if I'm using imaging, it's very easy. You can just see what is the amount of dissection that you've created. But if you're not using imaging and patient is not affording that, then we typically wait for a couple of minutes just to see what's happening to the vessel. Is it shutting down? Or what's the dissection like? So you typically wait for a couple of minutes before you DCB. Those couple of minutes usually help you to decide whether you can go in with the DCB or you need to stent. Typically, the acceptance is increasing because now more and more of my patients, I say that, okay, I'll put a stent here, I'll put a stent here, but here I'm going to just DCB the vessel. And there are many places, typically trifurcations, where you don't want to stent. There are many places, smaller side branch, I don't want to put in a stent, more metal, more restenosis, more. So many are the places where we are going more and more. And as you use more and more of the DCB, you actually realize the places where you can just walk away with it and the places where you need to wait and see whether you'll actually need to put in a stent. But having said that, there have been times when I've done DCB and the patient has had pain and I've brought him back and put in a stent over there. So there are, but it's a learning curve. Like we have a 20, 25 learning curve years for drug-eluting stents. There's a learning curve for DCB too.
Yeah, Praneeth, I have to, I have a comment for you. See, post DCB dissections should not be a kind of a situation in which one should be landing. DCB has to be given only when we are perfectly clear that here I'm going to paint the vessel with DCB with at 4 or 6 atmosphere pressure, which is not going to cause any dissection. So once we prepare the bed well, and we see that the dissection anyway, we are going for a stent. If we see that this dissection I'm going to take, which we have become more comfortable seeing dissections, leaving them like type 1 and type 2, and then after waiting for 5 minutes to 3-4 minutes imaging, and we are perfectly fine that okay, we are going to accept this, we just paint the vessel. Initial 10-15 cases, you are perfectly right. We had also this concern. We had inflated DCB over 6, 8, 10. We use that DCB balloon for even preparing the lesion and just going for the drug treatment. But that is not the practice which we are doing now. It's just in the final stage when we see that okay, now we have to go for DCB. We are going for DCB coming out, and if we are confirmed that no, we have to bail it out with a stent, we are going for that.
And it's also when you're going for a DCB, you have to do a 1:1 sizing bed preparation. And when you do a 1:1 sizing of the bed preparation, you're totally confident that now your DCB is going to just go in and inflate at that 1:1. So by that time, you already know the kind of dissections that you have in the vessel and you're clear.
Can we have Prashant?
I think the onus is now on Anand to invite even the peers to join us in our journal club, because they can also then benefit and keep open minds and maybe even sanction DCBs or not reject bills which come with DCBs and have the administration breathing down our necks. So I think it is our responsibility also to educate people around us. We don't complete the entire ecosystem. The pairs are also important, but maybe we can include that.
Yeah, the other question is about choosing your DCB, particularly if you are using a DCB for a side branch. You have deployed a stent, possibly a limus containing stent. Most of the stents are coated with everolimus, zirconium. So it's a limus stent. Which DCB will you use? It's a limus balloon or a paclitaxel balloon? And do you worry about the interaction between paclitaxel and limus versus the same limus which can avoid interaction? Any thoughts on that?
So I don't think there is such a kind of
There's no such data.
Yeah,
So we don't have data on that. Typically, it depends on what the patient's pocket will afford at this time because we don't have data on this.
And which balloon you have in yourself? Yeah.
I have all. I'm at Apollo Indore, so I have
Most of the time, both are available. So if both are available, which one will you
Many of
choose?
them, like there's not any data which is there or endorsements, and these are all.
Remember when we
I've
had
used all of them, But this is typically not to be said in an open forum. But I've had great results with solution.
Yeah.
So this is the same question which came when we had the initial days of treating DSISRs, and whether we are going to take a taxus restenosis with a cipher, or we're going to deal a cipher restenosis with a taxus. I mean,
Yeah.
I was reminded of that, which is almost like 20 years or 18 years ago, that these questions used to be asked. And unfortunately, I don't think we have
Solved it.
data to support this in using different drugs, or whether there is any interaction at all between the limasample or taxolid.
So there's still a lot of these questions, whether changing the drug will help when there's an ISR. And then again, the question that a lot of people ask that, you've already done a DCB there and you're going to put in a stent over there. So double the dosage of the drug is over there. Do you worry about that? I think time is only going to solve all of these answers.
So great. As always, we've had some great, interesting discussions, and we can hand this back to Anand and make it wait till the next time for the next edition. So we've completed over a year, which is a good journey, and we should actually take pride in the fact that we've roughed out a fair amount of political issues in the initial stages, and now we have a kind of smooth flow. So we thank Anand and his team, and give it back to him.
Yeah, thank you so much, sir. Thank you so much. I think just I was thinking about making something like a year in a wrap, something like this, or probably we have covered the top journal parade, like something a good groundbreaking discussions have happened in the past. We have created as an one repository called Ajanta Med Dialogue, where all those repositories already been placed, and it's under little engineering stuff. So very shortly we will release that issue as well for the resonating with the larger audience. To put it on record, once again, our momentum has came back with more than 1,600 interventional cardiologists joining in the today's discussion. And I think, yes, that's great success. And all thanks to the panelists for making it more useful and making it more real. And that's what, I would like to say here.